so that they could be supported. The crux here is to be able to serve our residents. In the current financial environment, it'll be prudent to expect the need for our service users to increase and yet have fewer resources. Welcome to the world where the expectation to deliver quality is also twinned with a reduction in the resources that are available. Good evening and welcome to the Future of Primary Care webinars. I'm Mohit Venkataram. I am a doctor by background and I am the Executive Director for Primary Care at East London Foundation Trust. When East London stepped into the arena of primary care, we were very fortunate to be working with some amazing GPs serving the vibrant and colorful populations we have the joy of working with. Our motive of stepping into primary care was firmly embedded in the drive to support our local GPs so that together we could provide a resilient out-of-hospital system for our populations. East London Foundation Trust, as many of you know, is one of the largest mental health, community health, and primary care trusts in the country. With the massive corporate resources we have, like education, training, assurance, finance, the ability to share that with our primary care partners would always help better services delivery. And this webinar series is one such attempt in creating a shared learning environment for us to together grow and provide better services. It also allows a space to acknowledge that actually we have a lot to learn from each other. But before I launch into the meat of today's webinar, some topical facts about primary care. A recent analysis has demonstrated that the GP share, that's the primary care share of the NHS spend, has fallen for the first time in 8 years, which means from 2015, for the first time in real terms, the amount of resource given to primary care of the overall NHS resources is less as a proportion than it ever has been. Now, was it King's Fund, the think tank, who very beautifully articulated this in saying policy does not match the ambition that's being set for primary care? In itself, this fact would not be as strong an indicator of the brilliance of primary care, but along with the combination that of the last published data set in November, primary care has seen 32 million people in that month alone. Almost 70% of these patients were seen face-to-face, and 41% of patients were seen directly by GPs. Now, those are startling statistics when we realize the actual spend in primary care has reduced as a proportion in real terms. I often stand back in awe and wonder how we could achieve transformation in a service that is so dear to our residents so that the power of change, the power of primary care could be in the hands of our residents. One such leader who not only thought about it, but also led the development of a revolutionary digital platform so that in the palm of our hands was the ability to start looking at our health so that we did not have to queue in to ring 500 times at 8:30 in the morning, but could make our appointments later in the day so that we could have better, more resilient services. And an architect of such provision Dr. Ellender is our guest today. We are incredibly fortunate to have him because well before he started this, he was already making a name for himself as the architect of one of the first group practice leads. He was the chief operating officer for Hurley, which then led on from 1 practice to 15 practices, growing from 15 staff to 600 staff, and providing some amazing GP-led primary care services. He has continued to maintain his clinical practice while leading this development. But before I hand over to Murray, just a reminder to the 300 strong of you who have registered today, please use the Q&A button to post your questions so that I can pull out the themes and use them for the conversation with Dr. Ellender. For those of you who have very kindly shared questions well in advance of this, and you can imagine the popularity of this webinar because the first question I started getting was in December itself, I will already pick those questions up. So please don't worry. Murray, thank you so much for joining us today. I am absolutely looking forward to this. So I'll hand over to you without further ado.
Great. Thank you very much indeed, Mohit, and thank you very much for inviting me both to you and to East London Foundation Trust. And I'm going to tell you a brief story really about why we started eConsult and what it does today, but really thinking about the future of primary care. What can it do for the future, and how can it continue to support the NHS, and particularly in that climate that you talk about of ever diminishing resources and ever increasing demand. And I think we have to look to technology to help us with this. So if I could have the next slide, please. Sorry, I'm going to say next slide, please, quite a lot here, but bear with me. There we go. Cool. I won't linger on this because this is the intro. Oh, we've lost the slides, but it doesn't matter. There was just a title slide while that comes back up, just to say who I am. But Mohit's given me a very kind introduction, and I am still a GP. I still work in both South East London and in East London as a GP with the Hurley. But that's a smaller part of my life now than running eConsult. And I'll tell you a little bit about why we started it. So if I can have the next slide, please. So as Mohit said, we actually started this in general practice because we were trying to solve a problem for our own practice and our own patients. And we had 15 practices, and we were slightly, I guess, frustrated that the model of general practice in all those practices was the same as it always had been. If you wanted to see a GP, you had to get on the phone in the morning, book an appointment, and come into the building to physically see us. And we thought there must be a better way of doing this. And we played around with things like video consultation, but as we've all discovered, video consultations, actually you still need a doctor and a patient for 10 minutes at the same time. And they often take actually longer than a face-to-face consultation by the time you've messed around at the beginning, trying to establish a connection and all that kind of jazz. So we put that to one side and came up with a different idea and thought, wouldn't it be great if you could gather the story from the patient up front and then put that in front of the clinician? So gather the history from the patient before they came into the building. So version 1, we really built for our own registered population of patients, which is about 100,000 patients in East London and South East London, and tested that and iterated the product there. And we started with the kind of 50 common conditions that presented in general practice. But to cut a long story short, it worked. We then ran a pilot in Tower Hamlets outside of the Hurley, got some good data out of that. And from there, GPs would approach us and say, this sounds really interesting. Can I try it? Which is when we kind of thought, okay, look, Hurley is a NHS GP partnership. It's not a good vehicle for selling software. So we formed a separate business and started selling it, eConsult, to practices, and initially selling it direct to practices door to door. And then over time, the NHS put some weight behind the idea of online consultation and actually created a market for this sort of tool. And it's now actually in theory available in all practices all across England. England, unlike Scotland and Wales, have commissioned it in all practices. eConsult is present in about 1 in 4, so there are other suppliers that do this, as we all know. And but we've taken the idea now and also taken it into A&E and also into outpatient. So I'm going to kind of tell you about that journey today. So if I can have the next slide, please. And actually, you can skip this slide and go straight on to the next one, because I'm going to talk to you about primary care first, because this is really where we came from. And this is actually how the platform works in primary care. So patients, we very much wanted to link patients to their own practice. So our view was very much, not if you want a digital experience, you have to register with a digital enabled practice. The view we came to was that actually every practice should have a digital solution. So patients, in fact, should have a choice of how they access their GP, either by phone or face-to-face or online. And so patients will go either through the practice website or through the NHS app. So obviously the NHS app knows which practice you're registered as a patient. So you can go in there, and if the practice uses eConsult, it's surfaced, the tool is surfaced. And that we ask a series of questions about your condition. So if as a patient you've got back pain, or you're depressed, or you've got abdominal pain, we will ask the same sort of history that would be asked if you were sat in front of a clinician. We then push this into the practice, and we say to the patient, you'll get a response by the end of the next working day. And I used to say that these were triaged by GPs, but increasingly they're triaged by other members of the practice team. And the idea is that you can actually close a lot of these consults that are coming in this way without bringing the patient into the building. And this is where the value is. And it's valuable for patients, but it's also valuable for clinicians. Because a lot of patients you can manage just by actually, if you've got enough information, you've got the medical record, you can issue a prescription, send it to the pharmacy and send the patient a message saying, actually, that uncomplicated urinary tract infection, we've sent you some antibiotics, you can safety net, you can offer all of that, kind of even empathy around that consultation asynchronously, but you can close that consult remotely. About 40% of the time, you have to pick up the phone to the patient because you want to clarify something in the history, or you want to explain the plan to the patient. And clearly, sometimes you have to bring the patient in to be seen, but actually that's less cases than you think. And the value there is that you're only bringing the patients in who really need to come in or who want to come in. And we found that the practices that really embrace these digital tools and get that kind of face-to-face consultation rate into a really manageable amount of face-to-face, and often offer those face-to-face appointments longer. So you can actually go, okay, I need 20 minutes with this patient face-to-face because they're more complicated. Or you can triage them according to need. So actually, I need to see this patient today, or this patient can wait and see the nurse next week, for example. But just the bottom line of this this kind of flow chart here just shows what happens if the patients aren't online. Because increasingly we've got practices who will also put those patients into the digital queue. So if a patient rings up and says, and it's kind of, the receptionist tries to divert them into an online channel, and the patient says, look, I'm not online. The receptionist can go, that's fine, let me take some more information. And they will ask a few questions, and they can put that case into the digital queue so it can be triaged in the same way. And that just means that everything's funneled through the same queue, which is much more efficient for the practice. So if I can have the next slide, please. And what we break down now, the kind of journey into general practice, into three kind of buckets, if you like. And this is what we provide as a tech platform. So there's the journey in. So there's how you actually send this structured information into the practice. So that's capturing the information, the history from the patient. If you click the slide again, then there's the way you present that information to the clinician. And historically, we used to, when we first started, we'd email it into the practice, and an administrator would, and anyone who's on the call who's been with us a long time will remember this, an administrator would take the PDF off the email and put it into EMIS or System 1. We then got a bit more sophisticated and learned how to push this stuff into the clinical systems. But we've now actually got an inbox that we've built that actually writes to the clinical systems in the background. There's then how the clinician responds. So we give the clinician the tools to respond, messaging, video, the ability to book an appointment. So you can push the patient a message saying, here's a booking link. And if you click once more, the final bit is also now how this increasingly works at scale. So we've got practices now that work across a group of practices to share the workload, and actually, certainly within the Hurley, we've got a virtual team now who can work from anywhere and manage this digital queue they've got access to the clinical record, they've got access to the inbox, and we can kind of tap into a workforce that actually historically would be very hard to tap into. And they can actually push the patient to the right clinician. So it really supports this new network working, which we're all becoming increasingly familiar with. If I can have the next slide, please. And this is just to show you what NHS England are now proposing as a kind of model for general practice. So, and this was issued last year. This is the NHS England model for modern general practice. And you can see it very much looks like actually what we offer. And so all practices are increasingly offering this. And, you know, the choice to patients of either calling in or walking in or submitting an online request. And actually, even if they do call in, we can capture that and put it into the digital queue. So it's starting to actually get the system to think differently about how general practice is open up. And that is partly how general practice is dealing with 32 million people last month, which is significantly more than we were 2 or 3 years ago. If I can have the next slide, please. So just a brief word on the inbox, very brief, just because it's important. I'm going to come back to it later. We spent a few years trying to push this structured information that we collect into EMIS, into System 1. And anyone who's worked with those GP systems knows they're not particularly receptive to innovation and moving fast. So we got to a stage where we could push a PDF into EMIS, but it was a bit clunky and lost in the system. And the problem then was as well, we didn't know then what the clinician did. So we've now created this layer, this inbox that sits between the kind of inbound information and the electronic health record. And it's where the clinician will operate. So they see the inbound consults and they can then action them. And it allows the clinician to kind of send the patient messages, write to the record, code stuff. But also, really crucially, it also allows us to start to understand what the clinicians are doing. So how they are managing these cases. And that will be really important for the future. So if we go to the next slide, please. And what we're starting to test now for more advanced practices is some artificial intelligence. So actually, we can start to understand what clinicians do with an eConsult, and then we can start to make recommendations. So actually, based on these symptoms, we suggest that this patient is probably GP suitable, needs a face-to-face, and is quite urgent. At the moment, we're kind of leaving a human in the loop, so we're not automating any of this today. And we can talk about class 1 device, class 2, etc. later on. But what we're doing is starting to help kind of nudge the clinician and introduce some intelligence that will improve the efficiency of the clinicians. So this is the kind of first step towards some automation. But what we're doing is we're bringing the clinicians on a journey with us rather than kind of forcing the technology on them. If I can have the next slide, please. And what I'm going to talk to you now about is kind of is urgent care. So what we did about 4 or 5 years ago is we thought, okay, look, this is great, this works well in general practice, but actually wouldn't it be great to digitize the urgent care journey as well? So that journey, when you walk into an urgent care center or an A&E, could we digitize that? And actually what we were thinking there is, and ultimately we could then tell patients that on this digital journey when they're in the A&E, next time they could do this from home. So everyone would be very familiar with the kind of old journey into an A&E where you arrive, there's often a long queue at the front door. And sorry, I'd be probably have to click a few times here because this is one of those annoying slides that builds up. But the old kind of journey is you queue at the front door, you book in with a receptionist, you then have to wait to see a triage nurse, and then you're back out in the waiting room, ideally for 4 hours, often for much longer. And then eventually when you see the decision maker, you have to tell the story again. Now, what we've done, and it's the same principle as the GP platform, but we're taking the history from the patient up front in the patient's time. Here, we do that via an iPad or a whole bank of iPads. So when they arrive in the urgent care center or the A&E, they see a whole bank of iPads. And on the iPad, it will ask them who they are, and then it'll ask them why they're there. So it takes a history from them. And behind the scenes, much like the GP platform, it's flagging. So it's kind of going, okay, well, actually, this symptom's a bit more urgent. You know, it'll build up a picture. So if you go in with chest pain that's regular down your left arm, it'll flag you as a kind of P1 case. We then push that information into the A&E system. So whether that's Cerner or Symphony or whatever the A&E uses. But what that does for the triage nurses is it gives them a prioritized queue. And we can identify within 5 minutes of everyone arriving, who they are and how sick they are. And this really adds value. And the next bit we're working towards is actually, if we could capture the observations while you're standing at the iPad, you could actually then, history plus observations, you could really kind of start to identify those sick people really early on in the journey. And then put the patient who really is sick into resus, the less sick patients down to minors. And ultimately, actually, the patients who don't need to be there start to push them back to general practice. And this is where we start to think about how you link some of these journeys up. So if I could have the next slide, please. So that's the A&E journey, and you can click on again, and this is it live. The probably most local site to Northeast London is the Homerton. We've gone live in the Homerton about 18 months ago, so they've been live for some time. We've actually now digitally triaged 900,000 people, not in the Homerton, but in about 10 sites across England, and we're going live in about 10 more over the next few months. So this is really starting to kind of gain momentum as a way to interact when arriving at an A&E. And the final door that we're tackling is the outpatient door. So if you think about what I've described, which is this idea of if you could gather history digitally from a patient before you go and see a clinician, we've applied it in a GP setting, an A&E setting. Of course, you can apply it in a specialist setting. So before you go and see a consultant, or someone in a hospital, actually, wouldn't it be great if we could gather more information? If you think about that historic journey into the specialist, you're referred by a GP. And sorry, this is not one of those annoying building slides. If you're referred by a GP, you then go into a physical hospital where you sit in an outpatient department and someone takes a history from you. You're then sent away to have some various investigations done, and then you come back at another time to have a specialist see you again and make a decision about a treatment plan. Now, you can already predict how actually some questions here would add some real value. So the pathway that we're testing, and we've got a big virtual outpatients we're creating out in Essex, across 3 hospitals, across 40 specialties, is when at the point of referral, we send the patient a very specific eConsult related to that specialty. So that could be cardiology, gynecology, it could be mental health. We send them something much more specific and richer, more detailed. That then goes back to the consultant, back into that inbox, and actually the consultant can then decide what they need to do. Do they need to order any tests up front? Think about potentially just advice and guidance back to the GP, but it allows the consultants to start to triage the patients in that secondary care outpatient environment. So if you could just click on again, these are some of the specialties we've got live, and this of the 3 products is the kind of one that's is in development. But we've got a lot of kind of early benefits emerging from this work. So the last thing I'll tell you about, and if I could have the next slide, please, is the future. And because I think and this is my last slide, and what we've talked about is the kind of the value of gathering structured information from a patient really on in their journey, because that saves the clinicians time when they do interact with that patient. And at the moment, the system is thinking very much in these silos of care. So it's actually commissioning kind of triage systems in general practice, triage systems in emergency care, and now start to think about how you triage in an outpatient setting. Ultimately, it would be really sensible if this was all joined up. And luckily, the NHS has started to think in ICS terms across kind of geographical settings. So, for example, Northeast London, great opportunity to start to think about how you might have a digital front door that when a patient enters from home, and they might come in through the NHS app or through other routes like a practice website or a hospital website, we can try to start to understand that patient's needs. So we can ask them questions about what they need. And then actually we can use the systems to route them to the right queue. So that patient that comes into general practice that maybe has a breast lump, rather than wasting journey time going to see the GP first, actually let's put that straight into the breast consultant's queue and just tell the GP that's what we've done. Or the patient who comes into A&E because they couldn't get in to see their GP for whatever reason, but actually has got a very GP suitable need. Rather than saying, oh, go and book a GP appointment, actually we can put that case back into the GP queue and we can say to the patient, your GP will ring you back later today. So you're starting to kind of move put the cases really early on into the right queues and different bits of the system. And that's the future that I envision. That's why where the kind of structured data at the beginning of these journeys really adds value. The last thing I'll say about the kind of structured data is it gives you a real opportunity to start to imply some intelligence. So when we talk, and I'm sure in the questions we'll get on to talking about some of the kind of the potential uses for artificial intelligence, in order to apply artificial intelligence to a clinical setting in this kind of environment, you do need to understand what the clinicians are doing when they're presented with cases. So actually, this is where the structured data adds real values, because actually, if you can start to understand what a patient needs and then what the clinician does at scale, you can start to then make predictions about, well, actually, next time, why don't you do this? And that's where I think the kind of the future lies, and that actually this is a system that has to be co-designed, not by technologists, but co-designed with clinicians and with patients. And that's the kind of future that I expect we're heading towards. And actually, it won't even be a question in the future about how you access care. It'll just be the norm to access. Your first point of call will be to do something digitally. And sure, there'll always be patients who aren't comfortable accessing care digitally, but they are, they will over the next coming years become the minority. And of course, we must still apply means to allow those patients to access them. But happy to talk more about kind of digital exclusion inclusion, because I've got lots of thoughts on that. But Mohit, I will end there. And if you want to just flick on, I think that's my last slide. Oh yeah, no, sorry, there's a few. That's just the point that there's inboxes at each of these. So we actually the inboxes help us move around the system. But yeah, I'm happy to share my details afterwards. And if anyone wants to pick up the conversation, always happy to. But I hope that was within my time allocation, and happy to take any questions now.
That was absolutely phenomenal, Murray. Thank you. Thank you so much. And while you wouldn't have seen it, the Q&A is already abuzz with people all sold on it, and many of them already praising stuff they've been doing with you. So it's phenomenal to see a leader like you taking on the digital platform here for us. A couple of questions to start the conversation about. So clearly, the digital revolution is the way one expects most services to go, but it also creates a different challenge, a challenge of inequalities. People who are not that savvy, people who don't access technology, people who are homeless, people who have barriers of languages, people who have different kinds of impairments. And while one is not talking about not having a phone line, that still exists, do you think there is any further technological advancement that will allow us to ensure technology was in the hands of a variety of us without it impacting inequalities further?
Yes. It's a really good point, and a very important one. I'm glad this is the kind of first topic we talked about, because I don't want you to think that I just assume that everyone can access digital stuff and it's all fine and the future's rosy. I mean, I think there's lots of good work that's gone into kind of digital inclusion, exclusion, and there's an organization called the Good Things Foundation, which has done lots of research in this area. And they've shown that about 90% of the UK population are online, but about 75% are active and comfortable interacting online. But that leaves a kind of decent cohort who have trouble accessing digital. And I'm absolutely not an advocate of forcing everyone down the digital path. I always say to practices or in an A&E setting, look, offer it up, but don't force patients down this route. If a patient doesn't have access, then let them come in another way. That's really important. But what we found is that actually, if you offer these digital tools, you can shift the kind of digitally adept, that's 75%, move them online. And what that does is it frees up the other means of access, the phone, the walk-in, for those patients who really struggle. And if you think about the kind of old world in general practice, where we forced everyone into a phone queue at 8 o'clock in the morning, those people who struggle to access care, that wasn't great for them then, right? I mean, they struggled then to access care because they were in the queue with 45 other people at 8 o'clock in the morning. So actually, we know that practices who've implemented this sort of technology well, they can spread the load through the day. It means the phone lines are less busy. And actually, those people who struggle with access, they find it easier to access care. And, and you definitely should still allow them to access care by phone or coming into a physical building. We should, definitely in an A&E setting, we don't force everyone to use the iPad. The role of the kind of receptionist becomes more of a care navigator, and they will help people who aren't comfortable using an iPad use that digital check-in. So, actually, if you can get patients to use the digital tools that shift the digital, we haven't done enough to shift the kind of digitally adept online and actually free up all those other modes of access for those who are less able. And that's really important. And the last thing, I'll be quiet because I saw it's come up in the Q&A, but about language, because language is, another kind of barrier to accessing this sort of technology. And I absolutely acknowledge that. We did a lot of the early work in Tower Hamlets, where, as we know, 70% of patients' first language is not English. What we actually found, though, was this wasn't a particular barrier to use, interestingly. And the patient would often be more comfortable or as comfortable sitting at home with an English-speaking relative going through an eConsult at their own pace than a kind of fairly high-pressured language line consultation. So it wasn't necessarily a barrier. And you'll ask me, okay, well, why don't you just translate the questions into other languages? And sure, we've looked at that. The challenge with that is, which languages do you start with? And you then, we keep this clinical content. It's constantly being iterated and evolved. So if you were to kind of go down the route of translation and you kind of had to translate this into 50 or 60 different languages, you'd have to then have a whole army of people keeping it up to date. And you then go, okay, well, just stick it through Google Translate. The problem with that is that actually there's some very sensitive clinical questions in here that determine risk. So if you stick the questions and the responses through Google Translate, who then is responsible for the risk? So I'm absolutely certain the future does lie in the kind of automated translations, because that's a much more efficient way of doing it. But we have to have some really serious discussions about, okay, then, well, if something went wrong because this was translated badly by Google Translate, whose fault is that? Is that mine? Is it the GP's? Is it Google's? So there's some things to work through before we get there. So we haven't solved all the problems, but this is a constantly evolving world. So very exciting.
Fabulous. And Murray, is there a forum where people can link in with you in the evolution of eConsult? Exactly as you said, because it keeps growing, and there are a few people who have commented and come back around, I have feedback to give, I don't know where to go. What should people do for that?
Sure. I mean, well, actually, we make it if they're users of eConsult, it should be we make it very easy. So if they're not users of eConsult, then I'd just drop me a line on the details you can see on screen, either for email or LinkedIn. I think if you're a user of eConsult, though, we offer clinicians the opportunity to feed in. At the bottom of every eConsult is a contact us form, because actually we like to hear about particularly clinical incidents. So, if actually if the clinician thinks, well, I wouldn't ask that like that, or we really value that feedback. The other thing is, within tools like the Smart Inbox, there's a way to have an instant interaction with us. So we man that kind of chat daily, and via our website as well. You can get on there, and there's a kind of talk to us button. And we've got a team that monitor that constantly. And we can then kind of siphon inquiries into a clinical channel. We've got a clinical team, or a more technical channel, or a product channel, depending on what the nature of the inquiry is. So we definitely, and then all that feedback that we take in from 2,000 practices, we then prioritize, so we can sort it into themes. And if there's clearly common themes of things that people are finding frustrating, that will go up our priority list of stuff that we develop. But we are a relatively small team. So I know there's lots more that we could do and I want to do. And one day we will, but you can't get to everything all at once, unfortunately.
So folks, you've heard it straight from Dr. Murray's mouth that please do feedback on your eConsult form. Please don't get disheartened because the change hasn't happened, because if there are thousands and thousands of feedbacks, there has to be a prioritization, no different to the triaging we do in our clinical systems. So those things that are high on the list or have a safety implication go much higher than others. That doesn't mean the feedback you have given is not important. It's extremely important, and it will be looked at. So please take heart in that. There's a really good question that someone's posted around face-to-face consultations. Now, I recall a time, I think I'm old enough to recall when everything happened face to face. Then came this really snazzy thing about saying, I've had 2 video consultations today, and that was the buzz of the world to get done 2 consultations that were video consultations. Then came COVID, and it's fascinating how people talk about the difficulty of reaching the care. It was the one part of health service that was standing up and seeing everyone. And it overnight moved to consultations online. Everyone had some kind of access so that there was some need being met as best as possible without causing risk to the population and to the vulnerable, because we know there were some awful, awful outcomes from COVID. Now, the world's changed again. People have started demanding more face-to-face consultations. And eConsult is actually a fabulous way for people like me who are working and don't want to spend all their hours sitting on making a phone call or waiting for a GP to automatically be navigated through a system and appropriately be assigned to the right person the first time. What's you about the triaging efficiency, given you have the most experience of running this, both first for your own practices and then wider for the system? Is there any data that actually shows the impact this has had on patient experience and on clinical experience?
Yeah, absolutely. I've got kind of thoughts on that for sure. I think, look, if you kind of take the average across general practice, and you touched on this at the beginning, 70% of GP consultations or primary care consultations are still delivered face-to-face. Okay, that's a high number. Pre-pandemic, it was 80%. So actually, the kind of myth that you sometimes see in the papers that we're seeing a lot less people face-to-face is actually a bit of a myth. Most consultations in general practice still happen physically in a room. Now, I will argue, controversially, we still see too many patients face-to-face if you look across the system. Okay. But happy to pick that debate up another time, because I think what happens in the practices that have really adopted digital tools well, their patients get used to this kind of way of accessing the GP. And yes, you always get patients who complain that I liked seeing my GP face to face, but actually we get the overwhelming feedback from patients is positive. So like 70, 80% of patients provide positive feedback on the experience, because actually it's much better than the old way where we used to make you come into a building to be seen, often when you didn't need to be. Now, clearly that's not always going to be, like, we're not always going to get it right. Okay, so sometimes actually there will be occasions when it probably does need it to be seen face to face, but as long as you kind of pick up on that and learn from it. And actually clinicians, I think if you give a clinician a rich amount of information up front, it arms them with a lot more to decide, well, actually, what is the best kind of modality for dealing with this? We always say, look, if patients want a face-to-face, give them a face-to-face. Okay, that's important. And I think, the other thing to recognize is actually, this kind of, it's often seen as a barrier. Like, you put this digital barrier in the way of me seeing the GP. Actually, we found there's a flip side to that. And particularly in conditions like mental health presentations, as you know, a third of general practice presentations have mental health. Often it's more than that. Or in conditions that patients perceive as embarrassing. So sexual health problems, or problems to do with going to the toilet and blood in your poo. Often patients prefer interacting that way, in an online way. So there's an argument to say, well, you could pick up more now, because, and certainly if you think about a kind of 22-year-old with anxiety, we used to kind of make them jump this huge hurdle and come and sit in front of me as a GP in order to explain their symptoms. They feel a lot more comfortable actually kind of interacting digitally. It allows us to kind of capture a PHQ-9 or GAD-7 up front, so there's lots of reasons why these digital tools, and add value to the overall system. And I think really important as well to say that there's still a clinician looking at all of these. Okay, we're not in a world where this is all automated and the machine's telling you, oh, don't worry, go to the pharmacy. Today, there's still a human in the loop. Okay, there's still a clinician, an experienced clinician, who is reviewing this information and making a decision, and that's really important. I don't know if it'll always be like that, But today, there's still a human in that kind of decision-making loop.
Fabulous. And folks, I think it's worth just recognizing that these are horses for courses. The right answer for the right patient isn't always the right answer for every patient. So we just need to work through the system that allows us to give the best experience and best clinical outcome for each of our residents differently. And I'm not going to read the whole question that's been raised by one of the colleagues, but I'm going to read a couple of comments they have made. Love the eConsult, thumbs, smiley, all that stuff on the chat box. So thank you for putting that out. I just thought I was going to read one of those just so that Murray knew how many people are crazy about him and his development there. I think one of the questions being raised is around the growth of the skill set in primary care with some fabulous roles like social prescribers, and how the eConsult pathway would allow the opportunity for people to be streamed quicker through that process rather than have to run through the traditional route. Do you have a view on that, Murray?
I do. I think, in the reason, part of the reason that general practice has been able to deal with about 25% more patients than we did, if you look back at the numbers in 2019. So that 32 million number is it was about 25 million pre-pandemic. And in the context of less resource and less GPs, so whatever the government may say, GP numbers have fallen. But actually what has happened is we've introduced new workforce into the skill mix. So the social prescribers, the pharmacists, the physios, the mental health workers are now part of that kind of wider primary care team. And actually, if you didn't have digital tools like eConsult, how would you get the right patient to the right clinician? The only way to do that is to have a GP, expensive resource, triaging everyone on the phone. So actually taking a history on the phone and going, okay, I'm going to book you in with our pharmacist. That's a waste of time, right? Actually, if you can gather some structured information up front and understand what the patient needs, we can then put the patient in the right queue first time without kind of having a GP triaging this long list of cases. So I think that is where the structured data up front really helps. And you can go, and actually, a physiotherapist is probably a much better person to see a patient with back pain than me. So actually, we can put that back pain into the physiotherapist queue. We can put that, patient with depression into the mental health workers queue. So that's where the structured data really adds value. And I think I'm going to combine this response a little bit with, I didn't really answer your question, Mohit, last about clinician experience as well, using these tools. And that's really important because, again, we've kind of enabled clinicians to operate in new ways. So rather than making a clinician go and sit in a building and do our 4-hour, 5-hour surgery, actually we can tap into clinicians who maybe need to work at more flexible hours. So they maybe want to do a session on a Sunday evening from home. We can give them a laptop and access to EMIS. And actually it means that workforce we can tap into is much broader and we can be much more flexible about how we apply it. So that's really important when you're thinking about not just recruitment, but retention. How can we retain and make the most of our scarce clinical resource? We should be applying the same in hospitals, and actually allowing consultants to do a clinic at a time that suits them after they've done the school run, this is where technology can really help the clinician.
Fabulous. Absolutely fabulous. And colleagues who have posted questions around technological details on metaverse and the use of self-sovereign identity, I am going to request my extensive digital knowledge is bound by switching a computer on and off. So at that point, I switched off. May I please suggest you post those questions directly into the eConsult platform, because I'm sure digitally minded people within Dr. Murray's would be able to then feed back on their views on that, rather than me pick it up in a forum which is more general. So
can I say something really brief on that? Because it's a really important point. Because I think, and honestly, people are very welcome to email me if they've got specific questions. But there is a real range of clinicians as users out there. That's certainly true, right? And you've got some clinicians who are still getting used to this idea of, hang on, you're giving me a whole list of eConsults to go through rather than telephone triage list. Versus now, there's a kind of more there's people who've been using the systems for 3 or 4 years who are going, yeah, I totally get this. Give me the automated version with the metaverse and the digital twin, and so there is a kind of range of need that we need to cater for, and I think that's fair, and that's why I think overall the system needs to invest more in technology and thinking about all this stuff, and then servicing this kind of range of both patient and clinician comfort in this digital world.
Super. And there are colleagues who've raised something very, very important. I mean, as clinicians, we are often talking about the vulnerable. And what an eConsult allows people with LD or those on safeguarding to be picked up so that they are supported through the pathway without getting lost in a system where, when you go digital, there are times there are some inadvertent impacts, and this is a big one around the risk. Do you have a view on that, Murray?
I do. I mean, I think that's why it's really important to be able to make sure these systems are interoperable with the wider system. So, and particularly, think about general practice. Often such patients, the more vulnerable patients, will be flagged on the system. So, an alert will come up on EMIS or System 1 if that patient contacts the practice, which is why it's really important these systems are linked to a patient's practice. Or, if you think about a hospital setting, they're linked to the kind of EPR. So actually, we can start to kind of pull those flags through earlier into our digital journey. And, we haven't quite got there yet. At the moment, I can only write to the EPRs. What I'd love to be able to do is start to read the EPRs. So I can start to understand, well, actually, this patient has diabetes, let me tailor my question accordingly. Or this patient is vulnerable, they have learning difficulties, let me kind of then tailor that experience for them accordingly. Really important. So that's a bit about interoperability and making sure these systems can talk to each other. I think the other thing is about allowing proxy access, which we do. So as well as allowing parents to consult on behalf of children, actually, often a vulnerable adult will have a proxy who they can nominate, who can complete an eConsult on behalf of them. We also we've got a clinical team who kind of author the clinical content. We then have a kind of plain English team who will take that clinical content. Average reading age in the UK, 8. Average reading age in London, 7. So we actually allow, it's all authored to make sure that someone with a reading age of 7 can cope with it. Where there's the odd medical term, we offer explanations of it. And once that's been through the plain English team, it goes back to the clinicians to make sure none of the risk profile has changed because of stuff that's been altered. But yeah, we're very mindful of that. Actually, again, it goes back to not wanting to force everyone down a digital path, but if you are encouraging the digital path, it should be accessible to as many people as can use it or want to use it. So hopefully that helps.
And there are colleagues also who have commented on the fact that actually the comment says, I find the online consultation really useful for my neurodiverse children. We do fill things in together, but it's made them far less anxious. And what a phenomenally nice way of doing using technology in a way that's more user-friendly for patients so that they do not feel the alienation you can sometimes feel with the advancing technological world we live in. The question then that comes in, Murray, though, is, and you articulated it beautifully around, there is this range of clinicians who would, from one end, embrace the latest technology, AI, smart inboxes, to the other end of people who would struggle with some very, very common things. Is there any training you think that should be looked at with the training? Because I recall 33 years ago when I became a doctor, and for colleagues who are listening to the us online, 300 of you, please remember, I keep reminding my kids, my age is still 28. They don't have to worry around the fact that I've been trained as a doctor for 33 years. But the fact is, the training for doctors, the training for clinicians has stayed static. It's just stayed static, okay? It's exactly the same. I meet junior doctors now who have done exactly what I did 33 years ago. And a part of you thinks the world is different. The expectations as a clinician are different. Do you have a view kind of training that should really be in supporting people so that when they come out trained now, they embrace technology in a way that supports the patients.
It's a kind of relatively easy answer, because yes, we should be doing a lot more to train the kind of next generation, or the existing generation as well. So I think there's something about the digital tools should be fairly intuitive to use. I think there is something about the kind of, or the move to the electronic health records that happened, 20 years ago in general practice and is still ongoing in hospitals. But those systems tended to require quite a lot of training. Now, when you think about a kind of modern tech system, when you pick up your phone, you don't need a lot of training on how to use your phone. So actually, we should be designing systems that are actually relatively easy to pick up and use. And that is totally kind of doable. And then we absolutely should be training both the kind of it's not just the clinicians, it's the kind of wider teams within a practice or within a hospital to make best use of this technology. That is actually one of I've had lots of conversations with NHS England about this, because I think what they've done is drive down the cost of this technology, which is the right thing to do for the public purse. Absolutely. The problem is that they expect a lot for 25p per patient per year in general practice, right? They expect a tool that is all singing, all dancing, and does AI and everything. Oh, and also they expect someone to train you how to use it. And I kind of think, look, actually, I think we really need to think harder about the kind of transformation budget that needs to go with this. This is it's not an ongoing forever cost. There's a bit of a kind of one-off. Look, how can we've got practices who clearly learn how to use these tools. They've kind of taught themselves. But how do we share this wider? How do we get every practice thinking, well, and fortunately, the NHS England is actually putting some money over the next 2 years in this transformation piece. I think that's really important. Like getting tools, helping practices, clinicians, receptionists, nurses, everyone think about how you make best use of these tools and get the most out of them, because otherwise it's a waste of time. And then I think we do need to go further kind of into training, nurse training, doctor training, and go, right, look, much like you, I was trained to see a patient face to face, and here's how you take a history, and but we still need to definitely learn those skills, but we also need to learn how to manage patients asynchronously. We need to learn how to manage patients both when we're in the room with them and when we're not in the room with them, because that is a new skill that we all must learn, and that applies to the kind of clinicians of today, but also the clinicians of the future. So how do we build this into training? Really important. Totally agree.
I think you're spot on in what you say, and I think there is need for us to rethink the expectations we have of our clinicians and to support them so that they are trained appropriately and come through right. I think there are a number of questions on this which I will consider, but there are a couple of really strong comments around how confused people sometimes feel when they know they are going through a triaging process, because that's not what they're used to, that's what they've heard. And if the expectation from the triaging is that they would be referred on to a consultant, a specialist, rather than have to come to the surgery at all, what's the mechanism of communicating back to many of these people? Because there's a specific comment made about elderly people who get confused to wonder, why have I been referred without the old systems of talking to your GP and being taught to do this? And what's your view on that?
Yeah, I think it's a good point, because we talk about kind of training the workforce on how to use these tools. I think there's also a much bigger exercise and some more energy that needs to go into explaining how things have changed to the whole population. There was a campaign actually that was run at the tail end of last year, but I didn't actually see it. So I don't think it was kind of, it needs to be an ongoing campaign that kind of says, look, actually the way you access services has changed. And you can now access your GP, your hospital consultant in different ways. Okay. So you should actually have a choice of how you access. It should be online or by phone or face to face. There's going to be new ways that we're interacting with you. And that's good for ththese reasons. So it's almost like a kind of like national campaign that explains this. And I think also something about, and again, this was part of the campaign, but I don't think that it didn't hit that hard. you may not be seen by a GP anymore.
Yeah.
You may be seen by a physio, a social prescriber. But and the next bit is, and this isn't just about saving money or there's not enough GPs. Actually, for what you present with, often that may be better. Actually, you having a medication review with a very experienced pharmacist is over 20 minutes or something. It's actually probably a really valuable interaction. So we do need to absolutely explain this more and better, because it's going to take a time for everyone to understand this. Absolutely. And until then, we need to deal with that, and we need to kind of answer complaints and say, look, I'm really sorry we didn't communicate this well, but things have changed. So yeah, I think a really important kind of public information campaign that needs to happen.
Spot on. And I think it picks up a number of points made around, would people be confused whether they come in, which symptoms require face-to-face interaction, which don't, what kind of interactions do people talk about an eConsult, what should they insist on seeing someone? And I think it's something that we all need to be educated on, both as and as clinical teams, so that together we can grow very similarly to the work we're doing in the webinar today of growing together. Now, we are coming to the end of this webinar. It's amazing how time flies when you're having fun, Murray. Any last words of wisdom from you before I close?
No, I mean, just to say thank you very much. I think we do have to, I do honestly think we're at the kind of start of this. I still would say we're in the foothills of the digital transformation of healthcare. Okay, so there's still a lot more that will happen and can be done, and a lot more digitally that we could do to kind of revolutionize things that, done carefully and co-designed with patients and clinicians, can really make the NHS a much more sustainable place for all of us. So yeah, I'm an eternal optimist. But thank you again for inviting me on. It's very kind of you.
Murray, breathtaking in one word, absolutely breathtaking. There are moments in your interactions with people when you're just hoping time would stay still, and this was one of them. It was just amazing to have you and to know you made such a difference. And so many people in their comments have spoken about how they've loved what you've done and what a difference it's made to their practice and their ability to provide good care. And this you've just recreated a very magical moment today. So thank you. Thank you so much. And
you're very kind. Thank you.
A couple of things that you said: win-win for patients, win-win for clinicians, but also the ability to identify people who are sicker than others much quicker in the process, so we don't lose the essential part of making sure we are reaching out to the right people at the right time, instead of missing them from what we used to be a very chronological queue. The time you've given today has been phenomenal, and thank you for that. And I especially recognize the fact that it's not just the time you've given today, the time to prepare for this session and our interactions before this. It is really, I'm very, very grateful to you for this. A big thank you to the amazing people today who have logged on, and 300 strong of you have kept this a buzz. There is no greater way of making these sessions come to life than the active questions and the comments you pose, including the wonderful reactions. I absolutely love the thumbs up and the smileys that are going on the screen. A big thank you to two people who in the background make all this happen, the amazing Ola and the wonderful Sarah. But for the two of them, this session wouldn't have happened. So thank you, Ola and Sarah. For colleagues who would like to join us for another session, we have another one next month from 7 to 8 p.m. on the 21st of February with Dr. Gillian Oro, who is one of the leaders in developing neighborhoods. So hearing from her what the benefits have been, how they've made it work, and the amazing outcomes they have achieved from Surrey would be the day. For those of you who would like to spend a couple of seconds giving us some feedback, please use the QR code on the screens and do take a moment to give feedback, because those feedbacks helps us build the sessions of future. Murray, a big thank you to you for today for coming again. And thank you, colleagues, for joining us. Have a wonderful evening. Bye-bye.
Thank you.